Welcome to the third session of this insulin therapy workshop. We are going to case number 8. Here we have a 48-year-old female. She is on metformin 500 mg 2 times a day. She is taking premixed human insulin 30/70 20/015 subcutaneously 30 minutes before food. Her fasting blood sugar is 100. It is controlled. It's in target. Post breakfast blood sugar is 150. This is also in our target range. But we done an HbA1c. It is 8.3. We need a target of 7%. It's elevated, 8.3. So, how should we manage this patient? If we only consider fasting blood sugar and postprandial blood sugar, there is no need to adjust or titrate or modify the insulin or OHA dose. But HbA1c is 8.3. One possibility is that patient may be missing insulins at many times over the past 3 months, but he took the insulin for the past 2 days, so that is why the current FBS and ppbs is in range, but the 3 months average is not in our desired target. But if patient is telling that he or she has not missed any insulin doses, frequent missing doesn't happen, that means we need to explore more into the cause for the high HbA1c. One reason could be the postprandial surge after the lunch may not be properly addressed. The patient has checked fasting blood sugar and post-breakfast blood sugar, but in our normal Indian diet, lunch is the biggest meal and post-lunch sugars are not often checked, and sometimes the post-lunch sugars may be very high, which is not controlled with the premixed insulin, and this results in 3 months average high value. Here, when we checked for this patient, post-lunch blood sugar is 250. It's very elevated. We wish for a target of 140 to 180. So how to tackle this problem? One best way is to add a regular insulin before lunch. It can prevent the post-lunch surge. But it is not a practical option. This is because taking an additional prick before lunch increases the number of pricks. One, also patient may be going for work or it can affect his routine activities. Patient may be traveling at that time. It is very difficult for a patient to take insulin from the office. He need to carry the insulin from his house to the office, everything, a lot of practical difficulty. Another option is to hide the morning dose of premixed insulin. I already discussed in the previous session. If post-lunch blood sugar is high, we need to hide the morning dose of insulin. But if the morning dose is high, already post-breakfast is in target range. If we further hike the morning dose at around 11 a.m. to 12 p.m. time, patient can go into hypoglycemia. To prevent it, patient can take a snack at that time. There may be patients who is not willing for both these options. In that case, we have to ask the patient to reduce the quantity of food he is taking for lunch, along with adding a voglibose at lunch. Voglibose is alpha glycosidase inhibitor, so that the complex carbohydrate is not split into glucose in the intestine in a faster rate, so the postprandial surge after the lunch will be low, will become less. Or you can add a ripaglinate. Ripaglinate is also a secretagogue. from an other class, and repaglinate has got a shorter duration of action. Repaglinate 0.5 milligram. This can be added before lunch, or you can add a DPP for inhibitors. Any gliptins. Gliptins mainly target postprandial sugar, because when we take food from the gut, GLP-1 is secreted. GLP-1 is the one that stimulates the beta cells to produce more insulin. DPP-4 inhibitors prevent the degradation of GLP-1, and so more insulin will be available, more GLP-1 will be available when food reaches our intestine, and more insulin will be secreted. So DPP-4 inhibitor is a group of drugs which mainly targets the postprandial sugar. So adding a DPP-4 inhibitors will also do. So option number 1 is adding in regular insulin before lunch, which is not very practical. I also do not wish to give this option to the patient because I know it's not practical. But there may be some patients who are willing, who is not going for any work, who is at home at that time, who is at house at that time, and if they're motivated, can consider. But that can be considered only when the post-lunch sugars is very high and you're sure that with other means you are not able to control it, like cutting down the portion size of the lunch, adding voglibos, repaglinate or DPP-4 inhibitors, or by increasing the morning dose of insulin. So that is all with the case number 8. Now we go on to case number 9. Here we have a 60-year-old busy politician. He has to travel very frequently. He is taking injection regular insulin 15, 15, 10, 30 minutes before food, and NPH insulin 20 units at bedtime. His main concern is he takes insulin 30 minutes before food. Suppose he plans the meal breakfast at 8 a.m. He takes insulin at 7:30 a.m. But at 8 a.m. he gets stuck with some activities. Some people come to visit him. He get engaged or involved in some discussions, and he misses the meal, which is planned 30 minutes after the insulin injection. And once the meal is missed, he develops hypoglycemia. So he's not comfortable with this insulin regime. By any means, he wants to change or some solution to this problem. This regular insulin, it is mandatory that it need to be taken 30 minutes before food, because if the regular insulin is injected subcutaneously, it will take at least 15 minutes to start acting. So taking it just before food is not the answer. But we have rapid acting insulin analogs, Lispro, Aspart, Glulysin. These all start acting immediately. So patient need not have to anticipate a meal 30 minutes later and take insulin 30 minutes before. Whenever he is going to take the food, he can just take the prick insulin shot and go to meal. Or even he can take it just after the meal also. So Lispro, Aspart, Glulysin. So this 30 minutes gap is not necessary, and changing the regular insulin to a rapid acting analogs is the answer. He's on 15, 15, 10. So regular insulin, he can change to any rapid acting analogs, the same dose 15, 15, 10. But as we are going to change it to another insulin group, suppose there can be changes in the pharmacokinetics, dynamics and everything, some changes. So we do not want a hypoglycemia to happen. So we start with a slightly lower dose, like we start with 12, 12, 8 instead of 15, 15, 10. In insulin Aspart 12, 12, 8, 12, 12, 8. We will retain the NPH like before. NPH 20 units. We are only going to change the regular insulin to a rapid acting analogs. Lispro, Aspart, Glulysin. You can any of these. Next case number 10. Here we have a 52-year-old busy doctor. He is on premixed insulin 30/70, 20/015, sub-Q 30 minutes before food. He is also having the same problem. He takes insulin at 7:30 a.m. evening, plans to take the dinner at 8 p.m. evening, but he misses the dinner because he gets stuck with his patients and he develops hypoglycemia. He also wants an insulin which need not be taken 30 minutes before food. Here the answer is, just like we have a rapid acting analogs, the same rapid acting analogs can be made into premixed. We have premixed analogs like aspart and intermediate acting aspart, protamine aspart. Just like regular insulin and NPH together forming premixed human insulin, we have premixed analog insulin. So common available in our country are 30% insulin aspart plus 70% intermediate acting insulin, which is also an aspart, which is attached with protamine, or 25% lispro with 75% intermediate acting lispro. This all can be taken just before the food. So patient need not have to wait for 30 minutes. Whenever this doctor plans for his meal, he just takes the shot and takes the meal. Or even there is no much issue even if we take the shot just after meal also, because it is rapid acting. So we have to shift the patient to a rapid acting analog in the same dose. I'm going to tell this is a graph showing the pharmacokinetics of the premixed insulin. If it is a premixed human insulin, you can just see there is a delay in onset of action and the peak does not always coincide with the peak of the glucose surge after the meal. But the rapid acting analogs, when it is available as an analog premix, it is more congruent with the peak of the glucose after the feed. So this hypoglycemia episodes also at 11 a.m. There's a few hours after the meal when there is no food, there can be hypoglycemia with premixed human insulin, but that is also less with premixed analog insulin. Next case number 11, we have a 60-year-old patient who is on insulin R, regular insulin 15, 15, 10 and glargine 20 units at bedtime. His fasting blood sugar is 110, postprandial blood sugar is 180, HbA1c 7.2. All are in almost reasonably perfect range. 7.2 is just only a marginal elevation from 7. The AD recommendation of HbA1c target is 7. But his concern is he is developing frequent hypoglycemic episodes at between 11 a.m. and 12 p.m. at noon time. So I want you to think about the best solution to tackle these problems. I have already discussed the solutions in the previous sessions. So this is the regular insulin. The problem with the regular insulin, which is taken, it is taken 30 minutes before food, but the duration of action of regular insulin is 6 to 8 hours. Here the patient is taking regular insulin at 7 a.m., taking food at 7:30 a.m. So regular insulin start acting at 7:30, peaks after 2 hours, that is 9:30, but after that there is no food in the gut, everything is get digested and absorbed. By 10-11, this regular insulin is still acting because the duration of action of regular insulin is 6 to 8 hours. But there is no food, patient is developing hypoglycemia. So one solution is we can shift to rapid acting analogs. Rapid acting analogs has got a shorter duration of action, like 4 hours, and the action or the levels is almost parallels the level of the glucose surge after the meal. So this problem is not present if you are using rapid acting analogs. So you can use rapid acting analogs. But is this a good way? There is another way out. You can ask the patient to take a snack at 11 a.m. Here there is insulin acting, but there is no glucose, there is no food. If patient takes some snack at 11 a.m., that problem is solved. Analog insulin is 3 times costly than the human regular insulin. If you are changing the patient to analog insulin, you are subjecting the patient to 3 times the more cost. There are many patients who cannot afford it. So a simple way out is to insist the patient to take a snack at 11 a.m. But if the patient is affording, if money is not an issue, you can start on analog basis. Next case, we have a 68-year-old male. He is on insulin R15, 15, 10 and NPH 20, 0, 20. He is having frequent hypoglycemia. How will you manage? Whenever there is a frequent hypoglycemia complaint, a common practice among most of the doctors is to slash down the insulin doses. But this is not the correct. We have to specifically add at what time patient is developing hypoglycemia. We should not cut down the doses. We have to make specific intervention. Like if hypos are developing when patient is not taking food after taking insulin, why should we have to reduce the insulin dose? We have to insist the patient to take food after taking insulin. If it is a regular insulin, 30 minutes after food. If it is an analog insulin, immediately has to take food. So do not change the insulin regime. If patient is developing hypoglycemia at 11 a.m. to 12 p.m. time, we have 2 options: reduce morning dose of regular insulin, or take a snack at that time, or change to rapid acting analogs. If patient is developing hypoglycemia at 6 p.m. to 7 p.m. time, that is pre-dinner, you have to reduce the morning dose of NPH, or reduce the pre-lunch dose of regular insulin, or take a snack at 6 p.m. If patient is having hypoglycemia at 12 a.m. to 1 a.m. time, that means this regular insulin which is taken before the dinner is bit high. We have to reduce the regular insulin dose or change to rapid acting analogs. But changing to rapid acting analogs is practically very difficult because of the cost. If hypos is getting at 3 a.m. to 4 a.m. time, early morning hypos, we have to reduce the night dose of NPH. And as a general rule, to prevent the nocturnal hypos, we have to ask the patient to take a bedtime snack also. Anything like fruits, some biscuits, a protein drink, or anything. Next case, we have a 55-year-old male diabetic admitted to the ward with mild soft tissue infection. Resident doctors writes the insulin dose as regular insulin according to GRBS. Patient is already diabetic, he is already taking insulin. But once admitted, the resident doctor is writing regular insulin is admitted according to GRBS. Is there a mistake? There's a lot of mistakes. Because here, if you write like this, patient is not getting a bolus insulin. Not basal insulin. So patient is not getting any basal insulin. Basal insulin is necessary to control the fasting sugar. If the last dose of the regular insulin, patient is going to get it at the night time. But the night regular insulin is not going to act till morning to control the basal sugar, fasting sugar. If the fasting sugar is not controlled, post-breakfast sugar will not get controlled. So if you write an order like this, patient will not get a basal insulin, he will not get a sugar control. And also, patient is taking fixed meals, breakfast, lunch and dinner. So pre-meal regular insulin should not be based on the GRBS at that time. It is based on the post-lunch, post-meal value. If post-meal value is very high, we have to increase the dose. But if you write an order like this, the post values are not checked. Suppose GRBS is 130, you will not give any insulin to the patient. And patient takes a food and sugar surges to 300. But this 300 will not be captured in this monitoring system. So this is not a correct way. Another patient, 66-year-old diabetic male, is in severe sepsis following lower limb cellulitis. His BP is 90/60. Patient is on altered sensory septic encephalopathy. Patient is receiving riles to feeding. RBS is 320. Resident doctors writes the insulin orders like 15, 15, 10 and injection NPH 00, 15. Is there any mistake? Here there is a mistake. In the previous case, you are not supposed to give insulin based on GRBS. Here, you have to give the insulin based on GRBS because patient is critically ill, patient is not taking a fixed 3 meals, patient is on riles tube, Riles tube means it is a continuous feeding, like 100 to 200 ml every 2 hourly or a continuous feeds, and patient will be getting 8 to 9 feeds per day. So 3 times regular insulin as a bolus before breakfast, lunch and dinner will not be valid in this case. And also patient with sepsis is very prone to develop hypoglycemia. So this patient requires insulin based on sliding scale. So sliding scale is a proper terminology rather than telling insulin according to GRBS. So we have to plan subcutaneous regular insulin Q6H or Q8H. If the sugar values are very high, you have to plan it Q6H. If sugar values are in the border range, you can plan Q8H. And our target blood glucose is 180 for critically ill patients, for ICU patients. If sugars is, we can have, this is the standard sliding scale used all over. There are 3 scales for an insulin sensitive patient, usual and insulin resistant. So 180 to 220, if it is usual, we will give 6 units, 220 to 260, 8 units, 260 to 300, 10 units, 300 to 350, 12 units, 350 to 400, 14 units, more than 400, 16 units, and more than 500, you have to plan insulin infusion. I told you the glycemic target for a critical ill patient is 180. There were trials, nice sugar trial and VISCP WESP trial, which compared intensive insulin therapy with a sugar target of 81 to 180 and conventional blood sugar target less than 180. And what they found that if we target for a strict sugar control in ICU or critical ill patient, it increases the mortality. So target blood sugar for a critical ill patient is 140 to 180, and insulin is only used if the blood sugar values goes more than 180. And for this critical ill patients or Riles tube or an ICU who will not be taking fixed 3-time meals, we have to use sliding scale. Case number 15, we have a 56-year-old female. She is diabetic. She is admitted with emphysematous pyelonephritis. She is having uncontrolled blood sugar. Patient is receiving insulin R 25, 25, 15 and injection NPH 35025. Resident doctors writes the order as GRBS monitoring Q4H. This is not the correct way to monitor this patient. Patient is taking basal bolus insulin. So the time or points at which the monitoring should be done is, as already discussed in the session 1, it should be fasting, post breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner. And basal bolus insulin doses can be titrated only if these values are available. If it is written like GRBS Q4H, there is no time specification. The post-meal values will not be captured properly. So you have to write 6-meal pattern of monitoring if the blood sugars is very high, so that you can streamline the basal bolus regime. Case number 16, we have a 60-year-old female. She is on premixed insulin 50-040. The first visit, FBS is 130, PPBS is 180. Second visit, FBS is 120, PPBS is 190. Then after that, all of a sudden, she is developing recurrent hypoglycemic episodes. You reduce the dose of the insulin to 30-020, still patient is developing hypoglycemic episode. There is no other signs or symptoms other than this hypoglycemia. What could be the reason? You can just think and tell me the answer. Or think about the answer. 50-040 was the initial dose, blood sugar value is very well controlled. All of a sudden, after some time, patient is getting the frequent hypoglycemia and it's not getting controlled even after reducing the insulin dose, and there is no other signs or symptoms. It is very odd type of hypoglycemia. Here the patient is receiving 50-040. So 50-040 means the patient should be using 100 IU per ml insulin, using 100 IU insulin syringe. In the usual insulin syringe, 40 IU insulin syringe, only you can take up to 40 units. Since the patient is taking more than 40 units insulin, patient needs to take 100 IU insulin syringe, which has marking up to 100 units. So if the patient is taking 100 IU insulin syringe, definitely the insulin should be also 100 IU per ml. But what happened here is medical storekeeper gave her 40 IU insulin syringe. So she is taking 100 IU insulin in the 40 IU insulin syringe. She cannot, the marking is only up to 40, and she pulled back the piston bit more, and approximately she takes 50 units in that. So 50 units in 40 IU ml insulin syringe means patient is actually taking 125 units in the morning and 100 units in the night. It is not 50. It is 2.5 times more, because she is taking 1.25 ml insulin. In 100 IU insulin syringe, up to 100 IU means 1 ml. So for 50 units in the 100 units insulin syringe means only 0.5 units. So the patient will only get 50 units insulin. But if the patient is using 40 IU insulin syringe, if the insulin is taken based on the markings, patient will be getting 2.5 times the insulin dose. And even if you reduce the insulin dose to 30/20, the delivered dose is still high, 75/50. That is why the patient is developing mysterious type of frequent hypoglycemia. So it should be always be a part while discussing with the diabetic patient. Just probe into and know what insulin syringe they are using. Case number 17, we have a 65-year-old male, diabetes for 10 years. Patient is on insulin R15-15-10 and glargine 20 units bedtime. His fasting blood sugar is 250, postprandial blood sugar is 300. How to proceed? Here the fasting blood sugar is high, 250. Postprandial blood sugar is not high, because this post breakfast is not high. This is the fasting which is the culprit. The difference is only 50. If you correct the fasting blood sugar, like if you fix it to 100, the postprandial blood sugar will automatically becomes 150. The difference is only 50, since the difference is only 50. To control the fasting blood sugar, what we need the basal bolus, basal insulin, and here we are using glargine. We need to hike the glargine dose. So here I increase the glargine dose to 25. But fasting blood sugar value, instead of improving, it worsened. I again increased to 30. Still fasting sugar value is bad. Then I got it. He's having somogi. He may be developing hypoglycemia at around 2 to 3 a.m. and it is because of the somogi phenomenon. Somogi phenomenon means counter-reactive hormones and everything will come into action. And because of this, the blood sugar values in the morning will be high. So ideally what we need, we have to reduce the night dose of glargine. I reduced the night dose of glargine to 10 units and the sugar values got fixed. How to know it? We have to specifically ask the patient to check the sugar at 3 a.m. or we can use a continuous glucose monitoring system. Now the Abbott is having continuous glucose monitoring system where the sensor is placed at the arm and it measures the blood glucose continuously for up to 14 days, but it is costly. The most simple way is, whenever you have a clinical suspicion, ask them to do a blood sugar value monitoring at 2 to 3 a.m. Case number 18, we have a 82-year-old male was detected to have diabetes 5 years back. Patient is on metformin 500 mg 111, glycoside 80 mg 101. So this is a reasonably high dose. His fasting blood sugar is a bit high, 150. Postprandial blood sugar is 200. HbA1c is 8.3. You are not very satisfactory with this blood sugar value, and you advised insulin, but patient is not willing. So this is the case scenario. How to proceed? You should. There is no answer here is there is no strict HbA1c target. HbA1c target need to be individualized. So usually kept HbA1c target is 7%. We can go up to 6.5% in young and healthy individuals. But suppose if the patient is having high risk for hypoglycemia, we should not target a very strict glycemic control, strict HbA1c. We can become less stringent. Suppose the duration of diabetes is long, we don't want a very strict control. because it is the already told in the session 1, it is the initial years after the diagnosis of the diabetes is the golden years, and if you get the best glucose control in these years, in long term patient will get benefited. But after a long duration of diabetes, even if you get a very good glycemic control, you will not get the benefit, because all the damage because of the metabolic memory or the legacy effect of the diabetic memory happened in the initial years. This is mainly due to the epigenetics, means the epigenetic changes happens and the metabolism becomes in a bad way. So long duration of diabetes, you did not be very hard on the patient. Patients having a limited life expectancy. Why do you want a very strict control? We want only reasonable control. We want a strict control to prevent long-term complications of the diabetes. But if the already life expectancy is limited, why we are bothered about long-term complications? Here the patient is elderly, 80 plus. He's not having a very long life expectancy. Then why should we be very particular about the HbA1c target? Let it be loose. Let it be less stringent. If the patient is having multiple comorbidities, we should not be very strict with the glycemic control. Like patient is already having diabetic nephropathy, all the damages of the diabetes has already taken place. There is no point in getting a good glycemic control after developing a diabetic nephropathy. And also, if the comorbidity numbers are high, if the patient develops a hyperglycemia, he can develop cardiac events and even death during that time. So our priority is to prevent hypoglycemia. Patient is having established vascular complications, already told. The patient is having CAD. If the patient is having cardiac coronary artery disease, patient do not like to. It is not wise to subject the patient to the risk of hypoglycemia by targeting a strict glycemic control. Because if a patient develops hypoglycemia, heart will not get glucose to work, and heart will use fatty acid as a source of energy. To oxidize the fatty acid, heart needs more oxygen than utilizing glucose. So already heart is receiving less oxygen because of the decreased flow in the coronary arteries. So that can precipitate acute coronary syndrome and cardiac events. So established cardiovascular disease, don't be very strict with HbA1c. Patient attitude is also very important. There are motivated patients who has glucometer at home, monitor the blood glucose at frequent intervals, titrate the insulin dose. You can have a strict glycemic control. There are very careless patients who will never do a self-monitoring of blood glucose, never care of timely meals and all. If you target a strict sugar or strict glycemic control, patient develop frequent hypoglycemia and patient will get upset, and sometimes he may even stop all the insulin. And also resources and support system is also very important. Suppose for the frequent monitoring of blood glucose titration, patient needs to have a home glucometer, have strips. These all are costly. So resources and support system, if the resource and support system, and also patient actually needs telemedicine services to frequently contact the doctor and titrate the insulin whenever the patient has confusion. So if the support system is not high, we cannot be very strict with the glycemic control. Thank you. Next, we'll have session 4. We'll wind up with this session now.